We probably start out genetically, and for other reasons the bone mass is lower. So we definitely don't want to wait till 65. And here I want to say that we don't have any large data telling us exactly should we do it at 55 or should we do it at 60. But if we go by that 10-year, everything is 10 years earlier, then it sounds fair to do it at 55 onwards.
I think,
That's true. What about you?
Yeah, very rightly put, Usha, because I think this was a matter of debate when we were working on the guidelines as to when to order for a DEXA. Because 65 age didn't suit our population because the average age of a woman is 68. So it really doesn't make sense to start doing your DEXA at 65. And like she said,
But I think even in countries where you have multiple children, you have 4 children and 5 children, and maybe your calcium intake is not the best, your diet is not the best, and your nutrition is not ideal.
Yes.
So in those women, and menopause sets in
Earlier.
So do you think there's enough scope for us to do it routinely?
No, that is why I think from the Indian Menopause Society, our guidelines, though we cannot call it level A evidence, we could just put it as level C. But hypothetically and thinking more logically, we felt that it is good to do within post 5 years of menopause. Within 5 years, if she also has some major clinical risk factors, for 5-6 very simple reasons. One is because the average age that a woman lives in India is 68. Second is the age of menopause. Third is the peak bone mass it is attained is much lesser compared to the others. And the fractures are also occurring 10 years earlier. So that means we need to screen at an earlier age, 10 years earlier, compared to the Western counterparts.
Absolutely. So every country, I think, has their own reasons for screening at a particular time. But in principle, I think, as all our experts have said, that it does not need to be done exactly at the time of menopause, but maybe wait for a few years, unless there are clinical risk factors present, and then you do the bone density right away. So this takes us on to the management of osteoporosis. You have identified your patients who have got high risk factors, you have identified the patients you have diagnosed the condition, and you've assessed the fracture risk, and now you're ready to treat the patient. So we have a whole lot of list over here of what can be done for patients, which include lifestyle changes and it includes therapies. So with lifestyle changes, the main important thing is, of course, nutrition and exercise. And I think all of us in our offices talk to our patients and say, take a lot of calcium, do a lot of exercise, walk. Just like we discussed earlier, how much exercise is needed. Similarly, I would like to know is how much calcium in a day a woman should have. What food contains how much calcium? So if she asks me, okay, doc, what should I eat? I should be able to tell her what she needs to eat to get that calcium from her diet. So if she's vegetarian, if she's non-vegetarian, I think we all need to know, what to tell the patient. So what do you normally tell them, Usha?
So I do a quick assessment of what they are eating regularly. There are many women who avoid dairy, or they may be avoiding greens, dals, for whatever reason, like you said, vegetarian, non-vegetarian. And then the National Institute of Nutrition from Hyderabad has said that on an average, Indian women don't get enough calcium. They only get somewhere in the range of 300-400 milligrams of calcium. So if we are talking about bringing them up to, let's say, 1,000 milligrams at least, so they need a supplement of, I do talk to them about how they can, increase their, through their food sources, and give them another 500 milligrams of calcium as a supplement. And food sources are, milk and yogurt and greens and dals. And dairy products, I think, are very important because like 3 cups of milk is equal to 8 cups of greens and about 4-5 cups of things like rajma. So you can't do so much of those. So you have to take more of dairy. So I do.
Yeah. So there are some challenges even with the diet. There is a nutritionist whom I know who says milk is meant for the babies of of, yes, you're right, for the babies of the animals who give milk. So if it's a cow giving milk, then it's the calf who's supposed to get the milk, not not your baby and not a human being.
I've heard
So,
one more thing.
yes.
Like, have you know any mammal drinking the milk of another mammal?
Yes.
So people who don't want to
yes.
push milk
So
will come up with all crazy
yeah.
arguments.
And now there is so much of lactose intolerance being diagnosed, and so a lot of people are not having dairy in short.
There's another thing which, the cows are being fed with a lot of chemicals, specifically a growth hormone line. So we're getting more of insulin resistance.
Yeah.
So therefore, most of the time, right from PCOS, we stop asking.
The voice is not carrying through it. We'll take the questions later. So what we want to say is that milk is, of course, and dairy products are ideal for nutrition and bringing up your calcium. But these are small problems, like say a urologist would tell a patient not to take calcium supplements because she's developing renal stones. So how do we give the calcium to that woman if there are certain situations where the diet cannot compensate, nor can the supplements? Toby, any ideas on that?
Yeah, I think that things have gotten a lot easier these days with the internet. So if you have a patient in front of you, you can just hit the IOF, International Osteoporosis Foundation's calcium calculator. And within about 50 seconds, by just asking her the questions on that, on what she eats, it will calculate immediately the amount of elemental grams of calcium that she takes per day. And that should be routinely done with every patient at menopause, or if she's diagnosed with low bone density. And then you only supplement to make up 1,000 milligrams of elemental calcium. You can go up to 1.2, but never over 1.5 grams per day. Because if you're going to go over that, number one, the patient will be constipated. Number two, you increase the risk of renal calculi, as you have noticed, but you do not increase the risk if you stay below 1.5. And number three, there is this whole question of probably cardiovascular harm, which to my mind has not been completely proven, but it is something to bear in mind. So I feel very strongly that dairy is the best form of calcium, but if you cannot take that, you sometimes have to supplement with more than 500 milligrams, but always keep your eye on the total. It would be the exception of patient that would need a gram of that doesn't take in any at all. You can get quite a bit by eating non-dairy calcium-containing products, and the calcium calculator of IF actually tells you what you can do to increase and to get to your goal of therapy. So there's, to my mind, no such thing anymore as a routine supplementation of calcium. It should be individualized per patient. You've got no excuse. It's on the internet. You can work every patient out. It will take you less than 1 minute.
Okay. So we've got the internet available to us, and we'll be able to calculate how much calcium she's getting through her diet and how much you will give supplements. Now, when you have to give supplements to a patient, there are so many available in the market. Which ones would you give? Which products would you use? Would you use something which is, there are different ones, like there is, I can't even remember the names.
Carbonates,
yes,
and
there's
your
carbonate, there's
citrates.
citrate, etc., etc.
And,
Are there any specifications as to which kind of calcium we should be using? What time of the day she should be taking it? Whether she takes it with a meal, without a meal, with milk, without milk, etc. Any special instructions to the patients? Anyone can answer.
I use carbonate because I think it gives us exactly the amount of elemental calcium that you get. That's really what I want to know, how much elemental calcium they're getting. Even though there is evidence to say that citrate is absorbed better, I'm not sure exactly how much to give. Because per tablet, the amount of elemental calcium is much less. Does it mean I have to give more to come up to that elemental calcium, or is it getting better absorbed? Since I don't know, and I know from the carbonate, I've been using carbonate and it's cheaper.
Very good.
I think we use more of carbonates for the very simple reason that it is much more economical than the citrate. But there are a lot of people who do have problems about this distension, and then then you would definitely like to think about citrate, and then you have to have the carbonate with after a meal, whereas the citrate you can have it any time of the day, and preferably to take it at night. And like Toby said, it's very important to do the calculation very quickly, and then try to supplement with the diet, and just give the supplements if necessary, and maybe because you should not be giving more than 500 grams per
Yeah,
dose.
there are patients who say,
Yeah.
I'm
You
happy
can't
to
have-
take 1000 milligrams
at a
together.
time.
Can
No.
I do that instead of taking 500 milligram twice a day?
No, the absorption then doesn't work like that. So you
Exactly.
have to space it over a period of
So
time.
basically the body doesn't absorb more than 500 milligrams at a time. So it's no point giving 1000 milligrams together. It's always 500 milligrams, if at all you're giving twice a day. Toby, any thoughts on this? Calcium absorption, calcium products?
Yeah, I completely agree with everything that's been said. And I personally would always start with a carbonate, but then change, because the patient will quickly tell you whether she's constipated or not, and then maybe change to something else. But just another general comment about supplementations. Supplementations are very badly regulated, and very often what is printed on the packet is not what's in the tablet. So it is probably, if you feel it is important for the patient to take a supplementation, to make use of a very reputable manufacturer, which can actually guarantee you that what's on the box is in the product, because you'd be surprised at what has been published at randomly tested products that has been sold as calcium supplementation.
So in short, yes.
Duru, I think there's a very important remark that I would like to make at this point of time, that is polypharmacy. And in India, we have so many formulations of calcium and vitamin D. And now the combinations of vitamin D which are coming out with calcium is, most of them, now we don't get the 400 IU, we get all the 1000 with the calcium. So we have now vitamin D toxicity because people consume the calcium and vitamin D, and they have the vitamin D alone, which is being prescribed. So this is now becoming a real major problem that we face in my practice. At least I've been seeing this change in the past one year. What do you say, Usha? Do you find that kind of problem? When you don't read the labels properly, like Toby said, and you don't understand how much of vitamin D and how much of calcium, or what are the other trace elements that go with it.
See,
and then there is a generalized prescription pattern.
I think till recently, maybe 3-4 years ago, routinely everyone was giving 1000 milligrams of calcium a day to postmenopausal women. I think everyone is becoming more minimalist with calcium and giving only 500. So I think
But
the
what
chance...
about the vitamin D? What's
Vitamin D
happening
is another
Yeah,
big
that's
thing
the thing. The
which she's
vitamin
coming
D
to
part
next.
is actually the next on my list, and
Very big question.
we basically would like everyone to understand what is the dose of vitamin D which a woman needs, probably at her at midlife. But of course, the whole process starts since she was a baby in her mother's uterus. Probably she didn't get enough vitamin D even at that time, and probably she needs to take enough vitamin D through the years. And what dosage is required for pregnant women, what dosage is required for menopausal women of vitamin D? Is there any difference in the doses? Do we need to give more to one group of patients and another? So there's a lot of discussion on what is the daily requirement of vitamin D, which for some time there was hardly any consensus on it, and it keeps changing, I think, almost every single day. There are different formulations available. There are granules available, there are injections, there are tablets, there are chewable tablets, there are non-chewable tablets, there are liquids. There are all kinds of vitamin D available. So honestly, I've seen vitamin D levels going up to 200 because people have been taking so much vitamin D. So I think a little discussion on that, if you all can just throw some light on this.
So I think first unquestionable truth in India is there is vitamin D deficiency. There's a lot of that, and the question comes up, why should in a country with so much sunshine there should need to be vitamin D deficiency? The changing lifestyles, everybody is indoors, then glass windows, and there's a lot of use of sunscreens, Fair and Lovely, and now Fair and Handsome. So the women and the men are getting, I think, hit with this sunscreen, and then air pollution, obesity. So many things are contributing to vitamin D deficiency. But then, I mean, that doesn't mean that everybody should get vitamin D. So to answer your question, if they are symptomatic, definitely we want to treat vitamin D deficiency, aches, pains, fibromyalgia, muscle cramps, specifically targeted screening. That's what I'm trying to say. If you have targeted screening and you find, I'm just telling you how, we practice. And the recommendations of vitamin D on a daily basis, whether you follow IOM or the Endocrine Society or the US Preventive Task Force, everything is so different. We really don't know exactly which one to follow. So if somebody is asymptomatic and you are just giving it to them as how much they should get every day, kind of a dose, then I think one is to definitely push natural sun exposure. There is no vegetarian source of vitamin D except some, I think, irradiated mushrooms or something. But other than that, there is no vegetarian source. Fish and egg yolks are sources of vitamin D in people who eat that. But even that, the fish that's eaten in India are not the ones high in vitamin D. So in all ways, I think this is not going well for us. So one will have to take a supplement if they are deficient. And for pregnancy and all that, I think there are guidelines on how we do that. But if they're deficient, how I use it is I give them, you want to know that?
Yeah.
I give them 60,000 units once a week for 8 weeks and then follow it up with once a month for about 6 months. Hopefully by then, whatever caused their vitamin D deficiency, we have worked on that. But chances are that once we stop, the levels will go down, sooner than later. So that's what we are seeing with that.
Yeah.
Which formulation to use? I've moved away from the powder sachets because they're just a little more difficult for patients to do. So either a liquid or a pill is what I'm using now. And also from injections. Except
You
for
moved away from injections,
Completely.
I hope. Yes. That's what I'm taking. So in short, we are talking about vitamin D. I think Usha has brought it up very well. If Toby, you or Meeta would like to add anything to that?
I think vitamin D is a very confusing subject, even to the experts. But I think that it's been well covered, and I would just I would not add anything else to just cause further confusion.
Okay. So we go on to the next medication, that's menopausal hormone therapy. Would you use menopausal hormone therapy as prophylaxis for prevention of osteoporosis? Toby?
Okay, I guess that's aimed at me. I think that we have to look very carefully at when and how we're going to use it. Menopausal hormone therapy is extremely effective at preventing all types of fractures. And we have that data from the Women's Health Initiative study. It reduces hip, it reduces vertebral, it reduces all non-vertebral fractures significantly. So it's fantastic medication. It's nature's own anti-osteoporotic drug. So the use of that has been curtailed by some confusion about the safety aspects, and that's basically the incidence of the effect on the cardiovascular system, the effect on breast cancer, and then the effect on venous thrombotic episodes. But we have all agreed that menopausal hormone therapy, when started before the age of 60, is generally safe, and that the advantages will be better than the disadvantages, or more than the possible disadvantages. So if you are dealing with a patient before the age of 60 who has a risk for fracture, then that is certainly the best form of therapy that you can give. Not only because it works, but because you really haven't got much of a choice either. Your bisphosphonates that have not been shown to really work in the patients who are just osteopenic, you need a minus 2.5 for bisphosphonate to work. The data on strontium ranulate was retrospective. The data on the SIMS were retrospective. So with menopause hormone therapy is the only drug where we have prospective randomized control data that it actually worked. So I have no doubt that for the patient with osteopenia of osteoporosis before the age of 60, that is the way to go. You can change it later on. I'm not going to go into all the aspects of the breast cancer, etc., but in the patient before 60, it's generally safe. The bigger question is whether you should use it for the osteopenic patient, risk of fracture that we typically diagnose in the early 60s. I personally believe that if you know what you're doing and you can assess the risk individually in patient, that it also can be used there. But what's absolutely clear is that any patient who is on hormone replacement therapy, for whatever reason, and that mostly would be for the control of vasomotor symptoms, you can assure that you'll have very good fracture protection.
Yes. And I can think of two other reasons where we would probably use menopausal hormone therapy in women with premature menopause, where I think it would be absolutely indicated at least till the age of natural menopause, where we must give it to them to help to protect them from all the aging processes which occur prematurely in them. And the second group of patients are the ones who are on GnRH analogs for a long time, probably for endometriosis or for some reason, and if you have to provide them with some estrogen, then you give the add-back therapy with menopausal hormone therapy. So these are two special indications where I feel, besides what Toby has mentioned, is there anything else you can think of?
No, I would just like to compliment Toby for, putting such a complicated matter so simply, a controversial matter so simply, because he has given that message very, very clear that menopausal hormone therapy should be probably offered as the first line of therapy for women in that particular menopause transition phase, which is so physiological.
May I say something?
Yes, sure.
The endocrines
And
are bound to
disagree.
differ.
No, I think the WHI and every trial has shown the benefit of menopausal hormone therapy in, hip fracture reduction, no question about it. But we also know that it's one of those things, unlike other osteoporosis agents, when you stop the therapy, the bone kind of goes back to where we started. So it's only kind of useful as long as we are using it. My concern in Indian patients is not any of this, but surveillance and them coming back for the recommended follow-up. So, my concern is giving a prescription for hormone therapy and them not coming back for mammography or for pap smear or for lipid checkup or any of those things. So, it becomes a niche kind of a therapy and not for everyone.
I think that's where the endocrinologist and probably the gynecologist would differ, because once you explain to the patient and you counsel them before any therapy, and and they understand, and I feel that they do come back if you explain to them. Like even for bisphosphonates, you definitely need to see them. For any long-term therapy, it needs counseling, and you need to get the patient back to you. So
The news is most of
Yes.
them don't continue it.
Yeah.
The average use of hormone therapy has been about
Yeah.
10 months to 12 months,
That's-
even when we prescribe it. So it's one of those, it's a difficult topic to discuss. I'm just saying, unless you're absolutely sure, the patient will follow up. See, we may counsel them, but they need to come back, and are they engaged in that? Are they aware of everything? To me, that is the most important thing in HRT.
So we have one of the,
Can I just
yes please Toby, go
And I
ahead.
just, that of course, you're absolutely right. I mean, if you're going to stop it, it's not going to work, and et cetera, et cetera. But the fact of the matter is that the time that patients stay on bisphosphonates are actually even smaller, shorter than the average time that patients stay on hormone therapy. So that is a problem of all osteoporosis drugs. And certainly if you want to use menopausal hormone therapy for that particular reason, you're going to have to take specific action to ensure that the patient stays on it. And also just in terms of the other drugs, when you stop a drug, it is only the bisphosphonates that offer longer protection after that, but all the other drugs are short-acting, even denosumab, you will lose the effect fairly rapidly after you stop. It's only with the bisphosphonates that you have the prolonged effect of the binding to both.
So with bisphosphonates also we have different formulations. We have tablets which are daily tablets, we have once a week tablets, we have once a month tablets, we have injectables. So there are many who do not tolerate the drug because of the acidity issues. And nowadays there are many centers or many clinics where intravenous zoledronic acid is being used. So how often do you all use it in your part of the world, Toby?
Bisphosphonates are still the most. Sorry.
No, I was talking about oral. Yes, orally they are used everywhere in the world. I'm talking about the intravenous ones.
So you're talking about specifically the intravenous one is zoledronic acid,
Yes.
which is given at 5 milligrams once yearly. And it has proven to be a very popular drug in South Africa, in my country. And many patients, because of the poor adherence to any of the osteoporosis drugs, they just find it so convenient. The side effect profile on the intravenous injection, it's actually an infusion that you give over 20 minutes, is actually very good. You do get what we call an acute phase reaction, which is a flu-like symptoms that the patient get for up to 2 to 3 days. But we have shown in some published data that you can actually prevent that by giving the patient a non-steroidal anti-inflammatory at the time of the infusion. So I think it's made a big difference to many patients in the sense that they tolerate it much better than the oral drugs. The cost is about roughly 2.2 times that of the equivalent oral dosage in South Africa again. So one has to motivate with third-party players to give that. But I personally think it's been excellent medicine. There's also now the latest extension of the Horizon trial has now been carried on for 9 years, and it's actually been shown that if after 6 years you stop the therapy, it virtually has the same effect if you do not give anything in the next 3 years. In other words, you will still have complete protection in years 6 to 9 if you have used it every year up to year 6. So it certainly has a long-term effect. We have one other form of an intravenous bisphosphonate in South Africa, which I don't know whether you got. It's called ibandronate, and it is easy in the sense that it's not an infusion. It is just a simple IV injection, which you can give in seconds, but it's every 3 months that you have to give it and not every year. One of the concerns about it that is not got the robust fracture anti-hip fracture data that you have in zoledronic acid.
Thanks, Toby. You want to add anything? Okay,
I
so
don't use the bandronate.
okay, no, but zoledronic acid.
Zoledronic acid. Oh no.
But you must be using a lot of parathyroid hormone, teriparatide.
It's only for very select.
Yeah. So
patients.
how do you select which patients do you give PTH?
So either someone who's coming to us right in the beginning with very poor bone mass, or someone who is fractured on a bisphosphonate, or someone who is not tolerating bisphosphonate at all. So these are very specific indications.
Yeah. So it's a very expensive drug and it needs to be given over 18 months.
See, the expense part has come down because I think there are local companies that are making it, but it's given over a year and a half to 2, and it's a daily injection,
Yes.
and so people have a lot of.
Yeah.
And then they have to be monitored for calcium, uric acid.
Yes. So Toby, the last one on the list is denosumab. Sorry?
Could I just
Sure.
ask, I'm very interested, so you do have generic PTH on your market, which is cheaper, is that correct that I just
Yes.
heard now?
Much cheaper.
Much cheaper.
Okay, because PTH is a wonderful drug. I mean, it's really the only anabolic drug we have at the moment. But it's been so expensive that it's virtually been a non-player in our country at least, because the cost is exorbitant. and but we do not have the generic one. So I think that if we have it at a lower cost, the indications would probably broaden a little bit. But I completely agree with the indications that you've given, which is in line with the IMS recommendations.
And what
You're
about
asking me about
denosumab?
denosumab?
Yeah.
Yeah, denosumab, unfortunately, we haven't got it available in South Africa. It's been sitting with our drug regulatory authorities for some time for reasons that I don't know, because virtually everywhere else in the world it has been cleared as it is a drug with very few side effects. It is an exciting drug in the sense that it is a so-called a drug that is it is aimed at a specific action, and that's the